Good evening, everyone. So, we will discuss a topic which is very important and it creates a lot of confusion. We'll talk about a topic which is called cervical cancer. There is a separate video where we'll talk about the FIGO staging of cervical cancer, but over here we are going to talk about the screening. Now, I'm not going to go into much details about the steps and the vaccines and everything of how to take a pap smear. We are mostly going to focus on how to interpret a pap smear and how to plan management according to cytology report and HPV testing. So the screening is started from 21 years of age and it is going to progress till 65 years of age. Okay, from 21 to 29 years of age, a female will undergo only pap smear testing. Clear? Every 3 years. Whereas beyond 30 years of age, she is going to have either a pap smear every 3 years or she is going to have a co-testing which is pap plus HPV DNA testing every 5 years. Now, how long should we continue the screening? See, a consensus has been achieved that 65 is the limit, but if the patient is HIV positive, then you are going to continue the screening annually, and 65 is not the limit. Okay, it may go beyond that also. Now, the common mistake is 21 to 65 is the age for cervical cancer screening. Okay, but 12 to 45 is the age for HPV DNA vaccination. Please be clear over here that even after giving the vaccine, the routine cervical pap smear screening shouldn't be interrupted. Now, what are the vaccines which are available? One is Cervarix, one is Gardasil, and the other is Gardasil 9. Now, Cervarix is only 16-18. This is 6-11, 16-18. This is 6-11, 16-18, 31, 33, 45, 52 and 58. Now it is given in both boys and girls. The frequency of dosing is 016, 026 and only 0 and 6. The adjuvant over here is aluminium phosphate. Aluminium phosphate. Over here is no adjuvant given. Okay, over here is alum is the adjuvant which is given. Okay, now this particular vaccine is going to protect us or protect the females also from cervical cancer. Not only that, this nonavalent vaccine, this Gardasil 9, is also giving protection. Recently it has been approved for all HPV related cancers, maybe nasal cancer, maybe oral, anywhere. All HPV related cancers you can give this. The most dangerous, the most common being 16. 16 is the most common to cause the serotype is the most common to cause cervical cancer. Now, after talking about the vaccines, we'll talk about the cytology report and how do we interpret it. See, so let us make a table. Let us make, before that, let us talk about the Bethesda classification. Now, Bethesda classification is given two classification. Previously, we used to talk only about, we used to say in 2001 to 2003, in that era, we used to talk about this is Bethesda classification as mild dysplasia, moderate dysplasia, severe dysplasia, or carcinoma in situ, okay, and normal. So this is the way we used to talk about. Then it came that, okay, let's put mild dysplasia under L cell and all of them under H cell. This is what it came to. Now 2014, the Bethesda has changed its classification and said that, okay, we'll divide the classification into two according to the squamous epithelial cells, because squamous epithelial cells is the lining epithelium, and we'll talk about the glandular epithelium, because we definitely know that the cervix has glands, especially the endocervix. Now, suppose the squamous epithelium. Now, squamous epithelium may be, number one, normal cytology, absolutely fine, nothing wrong with it. Number two, may be ascus. What is ascus? Atypical squamous cells of unknown, or you may also say undetermined significance. We don't know what it is. Even the pathologist doesn't know. It just looks atypical. Then the other one is ASCH. What is this? Again, atypical squamous cell, but you're going to add H cell, cannot be ruled out. Cannot be ruled out. Clear? Fine. Next, L cell, H cell, and basically you may talk about carcinoma in situ or just directly squamous cell carcinoma. Clear? Now, for glandular epithelium, number one is atypical glandular cells is seen. Clear? Second, atypical glandular cells these atypical glandular cells are definitely present, but we don't know whether these atypical glandular cells even have, like, they are favoring neoplasia. They are favoring neoplasia. So there are atypical glandular cells, but it is favoring neoplasia. Okay. The next one would be adenocarcinoma in situ. And the last one will be adenocarcinoma. There is no doubt with it. So basically we can see that this is the new Bethesda classification. Okay. Let's go on to further. Let's talk about the management. Let me just, we need to draw a table. So let me make this one darker. So management of cervical cancer screening, cervical cancer based on screening report. Okay. So number one is the cytology report, should be your first column, cytology report. Number two, write HPV DNA, write HPV DNA testing, and 3 columns under it. Number one, no testing done, and these two are testing done. This is HPV DNA negative, this is HPV DNA positive. Okay. Now we'll write what to do under each. So first one, normal cytology. The pathologist reports that there is normal cytology. So no testing was done. So continue with routine screening. Nothing. Acha, what do you mean by routine screening? Routine screening means PAP every 3 years or co-testing every 5 years. Clear? HPV DNA negative. What to do? Again, routine screening. Now, HPV DNA positive. This is the only case, I mind you. This is another, it may confuse you in an MCQ or even a clinical question, viva question. HPV DNA positive in a normal cytology patient, you are going to repeat the test after 1 year. Okay? Repeat it after 1 year, because in most cases it is just an incidental infection. It goes away. It goes away within a year. It goes away within a year. Clear? This is the only case where when HPV DNA is positive, we are only going for a repeat testing. Otherwise, in all cases where HPV DNA is positive, we'll go for colposcopy. Now, the next one is ASCUS. Atypical squamous cells of undetermined or unknown significance. So, what to do? Suppose no testing was done. When ASCUS is there and no testing was done, you are going to go for a repeat cytology at 1 year. In females, I can say 21 to 25 years of age, or basically you can write less than 25 years of age because 21 is starting. So repeat cytology at 1 year, 21, 25 years of age or less than 25 years. Or the best would be, please tell her to go for an HPV DNA testing. Tell her to go for it. Now, her report comes. On repeat cytology after 1 year, she has got cytology positive. Then she has to go for an HPV DNA. If she got cytology negative, you have to go for just routine screening. Now, suppose on repeat screening with HPV DNA, we didn't do it with cytology. We did repeat screening with HPV DNA. As I said, it was preferred. It came out to be positive. Please go for a colposcopy. As I said, any case of HPV DNA positive, colposcopy. If she had done initially, only she had come with a co-testing report and she has got HPV DNA negative, then you shouldn't tell her to do an HPV DNA after a year, because she has already done a co-testing initially. So you tell her, please repeat co-testing. After 3 years. Or if that HPV DNA was positive initially, directly colposcopy. Okay. Let's come to number 3. Now, number 3, everyone would be anticipating I'll talk about ASCH, but I'll keep that for last. Let me talk about LCIL. If it is LCIL, we have done, it is a low-grade squamous intraepithelial lesion. The person or a woman hasn't done HPV, but she has LCIL. Don't waste time for doing a repeat HPV and tell her to come. Tell her directly go and do a colposcopy, because there is a lesion. You'll go and you'll take a biopsy from that lesion, punch biopsy. You'll take the lesion and then you'll stage it and you'll find it out what the cause is. If the HPV, she had come with an HPV testing or a co-testing and the HPV was negative, then you tell, okay, don't go for colposcopy right now, repeat the co-testing at 1 year. Okay. Now, after that, if cytology and HPV both negative, do routine screening. If after co-testing at 1 year, she has found that the cytology and HPV is positive, tell her to go for colposcopy. As I said, HPV positive, colposcopy. And if HPV was positive, definitely colposcopy. This is the third column which I'm saying. Okay, so this is the first column, this is the second column, this is the third column. Fine. Let's talk about number 4 and 5 together. We'll talk about number 4 and 5 together. That is HCIL and ASCH. Immaterial of whatever you find, HPV positive, negative, we don't care. We'll tell her in all cases go for a colposcopy. That is what she has to do. Go for a colposcopy. Now, this 1 year, 3 year is very confusing. Remember, let us how to resolve them. How to resolve when 1 year, when 3 years. When an MCQ is given, it is, every time you get confused. When to repeat after 1 year, when to repeat after 3 years, when to give routine screening, when to go for colposcopy. So for colposcopy, I have very well made it clear, ASCH, HCR, HCL, whatever the cause, whatever the case, go for colposcopy. If there is in any other ASCUS or normal cytology even, or in cases of LCIL, if there is HPV DNA positive in any case, in any step, repeat testing or initially, you will go for colposcopy. Clear? Now, how to resolve this 1 year, 3 year controversy? Remember, any lesion has to progress through these stages. First, it has to be a CIN, which first there has to be mild dysplasia, which will form LCIL, and then it will form HCIL. So first there has to be atypia. Now, atypia doesn't mean LCIL. When you found atypia or atypical cells, it takes 1 to 2 years. It takes 1 to 2 years for this atypia to go into LCIL. And within 1 year, LCIL can progress to HCIL very rapidly. So see the total duration, 3 years. See this duration, 1 year. So if the patient has LCIL, you will tell her कि you go and better you go and do a repeat testing. If she has done HPV DNA, she has got negative, go for a repeat co-testing at 1 year. Clear? If she had atypia, which we were talking about ASCUS, so 3 years it will take time to go to HCIL. So we'll tell her you better go for a repeat testing, co-testing, not only testing, repeat co-testing after 3 years. This is for co-testing. Suppose she hasn't done her HPV. And she has come without doing that. Then how do you approach this case? If it was ASCUS, what did we do? We did repeat cytology at 1 year or an HPV DNA testing. We preferred HPV DNA testing. And for LCIL, what did we do? If for LCIL, she hasn't come with HPV DNA report. Why waste that 1 year for seeing whether the HPV DNA has become positive or not? Because LCIL within 1 year anyhow has high chance of progressing into HCIL. So if she has no report of HPV when she comes, tell her to go for a colposcopy directly. Do not waste time. Now, if she had ASCUS or atypia, I would very well tell her, okay, you do one thing, you go for a repeat cytology only after 1 year, or I tell her go for an HPV DNA testing. I would prefer this. Clear? Okay. I have forgotten to tell you, if the patient, let's see, if the patient has undergone an hysterectomy. What hysterectomy? For a benign cause. Okay? Like a fibroid. Then you can exclude screening. You may not do the screening anymore. But if malignancy was there. Now what kind of malignancy we are talking about? CIN 2 or 3. You will continue screening. There is high risk, you will continue screening. Clear? Okay. Now let's talk about what are the hysterectomy types. You know, there is a type known as subtotal hysterectomy. Where do we do subtotal hysterectomy? When at all, anyhow, even after arterial embolization, ligation, nothing, PPH isn't being stopped, you go for subtotal hysterectomy. That means you leave the cervix out. Cervix is left out. So in that case, you have to continue screening because the cervix is there. Continued. Clear? That could be a trick question. That you did a subtotal. It was a benign cause. Tell me whether you will do this or not. Screening. Yes, you will do screening because it is there. Now, an interesting thing to come. In rural areas, you do not have so much of pap smear and all that. So what do? We do a via or a villi. What is it? You take a posterior vaginal wall speculum, semispeculum, pull the posterior vaginal wall down, you pull the lip of the cervix up, and then you paint the entire cervix and vagina with acetic acid for via, and this is for via, and for villi we paint it with what? Lugol's iodine. Now the only question which comes over here is, over here stained area say you have to take biopsy. Over here unstained area say you have to take the biopsy, because take biopsy from, this is a question. So we know that there is proteins, acetic acid will coagulate it, help in coagulation of it. So definitely the aceto-white areas are the areas which has the dysplastic cells. But over here the pink areas, which actually is deficient in glycogen, will stain pink. It will remain pink, not stain pink, will remain pink because it is a normal color. So it's deficient in glycogen. Why? Because the dysplastic cells has high metabolic rate, has high metabolism. So those dysplastic cells will use up all the glycogen. So Lugol's iodine will have nothing to stain. The normal areas will stain with mahogany brown. Now, little bit extra knowledge for MCQ purpose. Mahogany brown color, where have you heard? Very good. You will remember that on gross samples of organs affected with amyloidosis, you stain it with Lugol's iodine. For the gross examination, it will appear mahogany brown. Clear? And the second is another mahogany brown tumor which stains mahogany brown color is oncocytoma. Clear? From the oncocytoma, from the distal tubular epithelium it arises. Anyways, renal tumor. Now, I'll not go into that. That was just an extra. It's next to say rural areas, we talked about it. Okay, let's come back to our cervical cancer. It's still not over, the screening part, because a lot of it is left. Controversial parts are left, which is, so we've done the via and the villi. Now, suppose on a colposcopy, you have done a colposcopy. Generally, remember the colposcopy you have to do under GA. Okay, you have to, it will require an OT. All these things will be required for doing a colposcopy. Anyways, while doing a colposcopy, you see a lesion. You take a punch biopsy. You cannot see a lesion. But the report had shown HPV DNA positive, or had shown that HCL or ASCH, and or it was LCL. The patient had come without HPV DNA testing. You've gone for colposcopy, you cannot see a lesion. It is very much possible a lesion is lying in the endocervix, so you need to do an endocervical curettage. You have a brush for it, you do it. Now we have all this. Previously, people used to do cone biopsy. Now this cone biopsy or conization is now mostly therapeutic. It is now mostly therapeutic rather than diagnostic. Mostly therapeutic rather than diagnostic. What happens? What happens in conization? We take a part of the transitional zone. We go a little bit above, we'll have the endocervix. We go a little bit below, we have the exocervix. So all the three should be there. All the three should be there. And we can find any. So endocervix, you know, the adenocarcinoma dominates, and the exocervix, you have what dominates? The squamous cell carcinoma. Very good. Sometimes you generally identify from where to take the biopsy in a colposcopy by seeing the transitional zone. Now the transitional zone has moved inside. When does it move inside? Menopause. Moves inside. When does it come outside? Move outside, just for the sake of understanding. Remember, pregnancy, very good. Puberty, very good. Pills, very good. So PPP. So PPP, 3 P's. It moves outside. Done. Okay, now next we talk about another procedure which is known as leap. And so large loop electroexcision procedure and leads, that is loop electroexcision of the transitional zone. These are two things we talk about. Okay, any one can be done. It is under, it is a daycare procedure. It can be under daycare or in the OPD only, and you cut and coagulate at the same time. You cut and coagulate at the same time. This is what you do in these procedures. I'm not going into the detail of the procedures, which we will talk in another video. So this is what summarizes the entire cervical screening and the approaches associated with it. Okay, so I feel that we have covered almost all the important parts or relevant parts associated with it. So that's fine. So let me revise it very quickly. Cervical cancer screening starts from 21 years of age. It will go up till 65 years of age. 21 to 29, do pap smear every 3 years. More than 30 till 65, do pap smear every 3 years or a co-testing every 5 years. How long? Till 65, unless if the patient has had a malignancy or is on chemotherapy, or if the woman has HIV, or the HIV annual screening needs to be done, and even 65 isn't the limit. That may go well beyond it. Now, previously, have the vaccine of Cervarix and Gardasil. The respective details of the vaccines are given. Bethesda classification, we had mild, moderate, severe. Now we have the squamous and granular. We've talked about the ASCUS, ASCH, LCL, HCL, carcinoma in situ, normal cytology. Irregular granular cells favoring neoplasia, adenocarcinoma in situ, adenocarcinoma. Management, suppose this is a very interesting thing. This is what is going to be given to you as questions and MCQs. So, normal cytology, in any case you'll do routine screening only if HPV DNA is positive. Sometimes it may be an incidental finding, so you'll repeat the test after 1 year. If it is negative, it's fine. If it's positive, colposcopy, excellent. ASCUS, what to do with ASCUS? Repeat cytology at 1 year if less than 25 years of age, or basically go and do an HPV DNA testing. It's much better than that. If after 1 year repeat cytology shows that cytology is positive, you go for HPV DNA. If cytology is negative, go for routine screening. If HPV DNA is positive in any case, you go for do colposcopy. Now, as I said, from ATPR to progress into HCL, it will take 3 years time. So repeat co-testing after 3 years. So we do, in case of HPV DNA was done and it was negative. Patient came with HPV DNA positive co-testing, you go for colposcopy as was spoken before. LCL, when we're talking about LCL, let's focus on LCL. LCL says, okay, since it takes 1 year, why waste time in doing, she hasn't come with a co-testing report, why waste time in doing an HPV DNA after 1 year? Go a colposcopy directly. When she has done HPV DNA and a test is negative, so then tell her to repeat after 1 year. If it is positive, colposcopy, negative, routine screening. If it is positive, she came with a positive report, colposcopy. HCL, ASCH, any case, colposcopy. As I was explaining, ATPR to LCL takes 1 to 2 years of time, LCL to HCL takes 1 year of time, so ATPR to HCL may take 3 years. So we can repeat after 3 years if she comes with an HPV DNA negative co-testing report. If she hasn't come with any report, fine. Tell her that you may repeat it after, repeat cytology after 1 year, HPV DNA testing, get it done. LCL, she came with an HPV DNA co-testing report, it was negative, repeat co-testing at 1 year. Because 1 year it takes time. If she hasn't come with that, why waste time? Go for colposcopy. Now, hysterectomy, we do a benign cause fibroid. You can exclude the screening. You don't need to do it. If malignancy, continue screening. If subtotal hysterectomy, continue screening. If she's on chemotherapeutic drugs for the malignancy, continue screening. Rural areas, we do via villi. You know the stained areas for via, unstained areas for villi, and we talked about it. Colposcopy, we generally do. We take a punch biopsy. We do an endocarditis. We cannot see the lesion. Cone biopsy was done previously for diagnostic purposes, now mostly therapeutic purposes. Anyways, we do it in this case. Now we'll talk about the surgeries later. Transitional zone, moved outside, moved inside, the respective causes, and the lead and the leads when done, what is done, we've talked about it.